by one after
Yeah.
some time. Yeah.
Relaxation.
To me, Harry, Anjan, you start with your welcome address and introduction of our expert.
So we are live now.
That's simple.
Okay. So, respected NEBOI members, I welcome you all for this 18th NEBOI classroom in this year. So, today in our classroom, we have our guest expert. He is Dr. Professor Rakesh Kumar. So, he is a very knowledgeable professor who is presently working as a head of the Department of Otolaryngology and Head and Neck Surgery of AIMS New Delhi. He is a Commonwealth Fellow in facial plastic since 2014. He is a visiting consultant in IIT Delhi, IGIMS Patna, and AIMS Rishikesh. Professor Kumar has conducted more than 50 surgical workshops on facial plastic, rhinoplasty, otology, and face at AIMS and other parts of the country. He has 80 research papers in peer-reviewed national and international journals. Presently, he is the president of AOI Delhi, chairperson of Committee of MDH4, ENT Instrument Sectional Committee at BIS Delhi. He again was the past president of NES in 2017 and 18. Again, the Secretary of Society of Facial Reconstructive Cosmetic Surgeons of India. Presently, he is into 10 government cochlear implant programs. His area of interest are facial plastic, airway surgery, and cochlear implant. So he is into a very diverse field. So with this brief introduction, may I request every one of you to join hands in welcoming our today's expert, Professor Dr. Rakesh Kumar, sir. So I hope every one of you will be very much benefited with this deep insight into this subject. I welcome you, sir.
Thank you. Only small correction. Now I am past president of Delhi OI.
Yeah, past
president. Okay.
Just now we had the annual conference, and now the president is Dr. Gupta.
Oh yeah.
From
sir.
UCM and GTB Hospital.
So, good evening and welcome to NEBOI Classroom. I am very happy to introduce today's speaker, Professor Anandita Das, who was my student at Guwahati Medical College while doing her postgraduate. She is presently professor and head of the Department of ENT and Head and Neck Surgery at Tinsukia Medical College. She has 16 years experience in medical colleges of Assam, passionate about clinical training, surgical excellence, and research in otology, rhinology, rhinoplasty, and thyroid surgery. She is two-time awardee of L.H. Hiranandani 2 at NEBOICON, our Northeast Association of Otolaryngologists of Indian Conference. She is fellowship in endoscopic sinus surgery at Hong Kong and also narrowband imaging at New Delhi. She did fellowship in mini rhinoplasty at Indore under Dr. Brajendra Brasil. She also conducted and
that's good, yeah, really good. I'm so
hands-on workshop in rhinoplasty, otology, airway surgery, and coagulation surgery. Our moderator of today's session is the Professor Biraj Kumar Das, who is presently Dean of Shillong Medical College, Meghalaya. Professor Biraj Das is a highly accomplished academician and clinician with more than 38 years of experience in service, teaching, and in the field of research. Professor Das served as professor and head of the Department of ENT at different medical colleges of Assam, especially at Jorhat Medical College and Fakhruddin Ali Ahmed Medical College, Barpeta. Subsequently, he had headed and served as principal at PA Sangma International Medical College, Boridwa, Meghalaya. Professor Das has publication more than 40 research papers in peer-reviewed regional, national, and international journals. Presently, he is the president of Northeastern Branch of Association of Otolaryngologists of India. With this brief introduction, now I invite Professor Anandita Das to deliver her presentation. Over to Dr. Anandita, please.
Thank you so much, ma'am, for the kind introduction. And can I share my screen?
Yes.
Now will not be in screen. Well, you will see the speaker.
Good evening, my respected teachers, today's expert, Professor Rakesh Kumar, all my senior and junior colleagues. Before I begin my talk, I would like to take a moment and pay tribute to Jubin Garg. He was more than just a singer. He was a maverick, a free spirit who lived on his own terms and whose music carried the emotion of an entire generation. His commitment to his craft and to the people of Assam made him more than an artist. He was a voice of identity and of belonging. Like all mavericks, Jubin challenged the norms. He experimented, took risks, and poured his soul into his craft. He reminded us that excellence is not about conforming, but about having the courage to be authentic. Today, as we talk about shaping the form and restoring the function of the nose, let us keep in mind the inspiration of Jubin's life to remain committed to our craft, to serve our people, and never lose the courage to be different. So,
Can you come closer to the microphone a little bit?
yeah, is this okay?
Yeah, it's
Am
fine
I
now.
audible?
Voice is
Yeah.
not coming nicely.
Yes, you come closer to the microphone.
Is it audible now?
Yeah, it's far better.
Yeah, okay. So, rhinoplasty, today's topic will be on the principles practice of rhinoplasty and some pearls for the ENT surgeon who are keen on starting their journey of rhinoplasty. Traditionally, rhinoplasty was seen as a cosmetic procedure. So, what do you do when you see a patient like this? When you see a patient like this turning up in your clinic who has a severely crooked nose, and on clinical examination, you see a severely bent septum. His radiology gives you a picture somewhat like this. So for ENT surgeons, form and function, they go together. As ENT surgeons, we have a deep understanding of the nasal anatomy and function. So rhinoplasty is a natural extension of our skill. There is a lot of evidence supporting rhinoplasty as more than just a cosmetic surgery. This was my study published in the Indian Journal of Otolaryngology and Head and Neck Surgery. And this study reveals that improvement is not just cosmetic. Patients with all levels of deviations reported both aesthetic and functional satisfaction after rhinoplasty. So rhinoplasty has a dual role. It helps patient in improving airway in cases of DNS, LR collapse, crooked nose. It can be due to trauma or congenital, and a variety of other deformities. It can also be used to enhance the facial features. The first rhinoplasty surgery is credited to the great Sushruta, during whose time nasal amputation was a very common form of punishment. He devised a forehead flap to recreate the nasal tip. His method was then carried to the Western world by the Britishers, and during the Renaissance period, rhinoplasty flourished all over Europe. The Italian Gaspar Tagliacozzi devised the arm flap method to recreate the nasal tip and dorsum. Then the era of reduction rhinoplasty, where excessive hump will and aggressive cartilage was done. This often led to long-term failure and airway prolapse, which was then addressed by structural rhinoplasty, where the concept of preserving the support structures and cartilage graft was propagated. And now we are into the era of preservation rhinoplasty, which believes that less is more. We'll be talking more about preservation rhinoplasty in my subsequent slides. Success in rhinoplasty starts even before entering the OT. Although a detailed history, clinical examination, and pre-op photos are vital, but the most important step is the counseling. Some of the patients have unrealistic expectations, and nowadays, due to social media culture, well, people uploading their photos and fees, I have my patients who want their nose celebrities. I was once approached by a young boy who was a walking, talking rhinoplasty encyclopedia. He wanted his nasolabial angle to be 90 degree, his nasofrontal angle to be 130 degree, the nasal tip projection to be accurate like the Goods triangle. So he clearly was a red flag. Always remember, if expectations are unrealistic, no technique will satisfy the patient. If operating in a private setting, it is always better to have a very detailed consent form. So once you consent to do the surgery, do a detailed inspection of the face and then the nose, focusing particularly on the nasal skin. Both thick and thin skin patients have their own advantages and disadvantages. But remember, nasal skin is thinnest over the nasal dorsum and thickest towards the root and also the tip. While palpating the nose, it is very important to check for the strength of the cartilages. Doing the tip recoil test gives an accurate assessment. The Cottle's test also gives information about any underlying internal nasal valve collapse. Nasal endoscopy is essential. I was once attending a workshop at Dr. Brajendra Basir Sir's place at Indore. Intraoperatively, Sir decided to do a nasal endoscopy because this was a patient who was previously not examined by his team. During the endoscopy, we found that the 24-year-old male patient, he had a grade 3 adenoid. The primary physician who had sent the patient had attributed his nasal blockage to his severely crooked nose. So this was a learning lesson, and doing an endoscopy is always a must. We have to evaluate the septum, the turbinate, the internal nasal valve, and also the nasopharynx. Photographies are mandatory. These are essential while you are consulting with the patient, while you are doing preoperative planning, and these also serve as a reference point during your operation. Post-operatively, they'll give a good basis for assessment of your results. And if there is any medical legal issue later on, that's essential. So while taking a photograph, you have to place the patient behind, in front of a light colored background and arrange the photographer to be around 6 meters distance from the patient with two flash on angled at the patient at 45 degrees, somewhat like this. This is a short clip of how photographs are taken. Hello? Hello?
Yeah, you're audible.
Hello?
Yes,
Yeah,
yes,
yeah,
you are
please carry
audible.
on.
Oh,
Carry on.
as everything went still, so I thought I might have lost connection.
Audible,
So moving
audible,
on
no
to
problem.
the next.
You're speaking very well, so go on. Yes.
So the skin soft tissue covering of the nose is made up of 4 layers. Just below the dermis is the superficial fatty layer, below which is the musculoepineuritic layer, which is continuous with the musculoepineuritic layer of the face. Below this is the deep fatty layer carrying the vessels, and below which is the perichondrial periosteal layer. The upper 1/3 of the nose is bony, consisting of the paired nasal bones and the frontonasal processes of the maxilla. The middle third is formed by the paired upper lateral cartilage with the dorsal border of the septal cartilage in the middle. This is best illustrated in this picture. And the lower third is made up of the paired lower lateral cartilages, consist of the medial crura, the intermediate crus, and the lateral crus. Here, I would like to highlight that the dorsum of the nose has a fusiform appearance due to this bony cartilaginous arrangement. And we should train our eyes to see the bony cartilaginous nasal dorsum more like the top of a plateau than a mountain peak because of the border of the dorsal border of the septum, which is interposed in with the upper lateral cartilage. This slide summarizes the key proportions and reference points we use in nasal analysis. Here you see the angular relationship of the nose to the face, the nasolabial angle, which is acute in case of males and obtuse in case of females. Then you have the nasofrontal angle, the nasofacial angle. In the top right, this highlights the important tip dynamics. Finally, the colored diagram here at the bottom right, it emphasizes the tip rotation and the tip projection. So in rhinoplasty, analysis is everything, because if you aim at the wrong target, even perfect execution won't give you the right result. The aesthetically pleasant and natural nose always exhibits double light reflections when photographed with a paraflash. The lateral profile shows that no actual hump is present, and the oblique view of the dorsum reveals the natural hump that is due to the fusiform structure of the nasal dorsum, and you can see the suprachiasmatic break here. So when we take photographs, we take quite a few views. So this is the frontal view. The position. Remember, the patient should always be positioned with the Frankfurt horizontal to the floor. So this is the frontal view. Then we have the right and left profile view, the right and left three-quarter view. Then this is the three-quarter basal view, and this is the basal view. There are additional views as well, like the helicopter view, but I like having this view because this is the view that we see while operating the patient. This is how we see the patient while operating from the foot end of the bed. And this helps us to assess our post-op results in the table, on the table, sorry. So from the frontal view, we assess the facial proportions, the nasal deviation, the bony vault, the mid vault, the dorsal aesthetic lines, the tip, the alar base, the alar rim, and upper lip. From the profile view, we see the nasofrontal angle, the position of the radix, the nasal dorsum and length, the tip projection, the tip rotation, the alar colomellar ratio, the periapical hypoplasia, and the lip-chin ratio. The basal view gives us information about the nasal projection, the shape of the nostrils, the columella, the alar base, and the alar flare. I'm not going into details of this analysis here because this is a topic in itself. And since we are short of time, I'll move on to the next slide. So which approach? Rhinoplasty can be done via the endonasal or closed approach or the external or open approach. Endonasal approach gives us limited exposure, so it is useful if you have to do very less work, as the post-op edema is very little by this approach. Open approach or the external approach gives a wide exposure and is useful for complex nasal deformity correction and also for teaching
Your slide share has gone. Hello?
Voice also gone.
I
No,
think
I
she
think
lost the connection, no?
she'll come again. I think.
Hello.
Okay.
Network goal jan paisu.
Mm.
That's why now we have to record it first. This is more important.
Hello.
Yes,
Yeah.
yes, you
Hello.
are audible. Please, please. Yes, audible.
Yeah,
I don't
Anindita.
know. Yeah, it became
Anindita.
mute.
Yeah.
Yeah. So, where do I start off from?
You share your slide first.
Okay. Share screen. Okay. So, yeah. Am I audible?
Yeah.
Yes,
Hello.
Yes, yes,
yes,
audible.
you are audible.
Yeah. So, which slide should I start from? This one, surgical approach, or this one? Hello.
Which approach? Yes.
Yes, yes, yes.
So yeah, so the endonasal and the external approach I had already discussed. Do you want me to repeat this slide again?
Yeah, you can repeat it.
Yeah, okay. So rhinoplasty can be done by the endonasal as well as the external approach. Endonasal approach, it gives us limited exposure. So it is useful if you have to do very less work, as the post-op edema is very little by this approach. An open approach, it gives a wide exposure and is useful while addressing complex nasal deformities. And it is also useful for teaching rhinoplasty to our students. So don't hesitate to use open technique during your learning phase. So this is an overview of the surgical approach that is done during rhinoplasty. I have written down all the steps. So we start by infiltration, marking, incision, flap elevation, and I'll be discussing this in the subsequent slides. So the prelude to a good rhinoplasty surgery is a good infiltration. So we use 1 in 1 lakh adrenaline in generous amounts during the surgery. Basir sir, he always says that if you don't want to have a long operating time, always spend a long time during your infiltration. So nowadays, if adrenaline is contraindicated, we have also started infiltrating with coal saline. So these are very short clips highlighting and showing the way we infiltrate. This is infiltration of the columella. This is infiltration of the vestibule. Where we give the infracartilaginous and the rim incision. And this is infiltration of the septum, nasal septum. Infiltration of the nasal septum is done as we do it in septoplasty. So again, this is another clip showing infiltration over the lateral nasal wall. This is where we do our lateral osteotomy. So we infiltrate it at the beginning of the surgical procedure and also while we are doing the osteotomy later on. So this is infiltration over the nasal dorsum. This is a clip showing trimming of the nasal vibrissae. This may seem trivial, but it's the difference between a clean surgical field and an obscured surgical field, and significant patient discomfort if the vibrissae are not trimmed. They have it in the post-operative period. So this is the incision. So I'm showing you the open rhinoplasty incision. So this is the columnar incision, mid-columnar level incision. The only principle, the different types of incisions have been described in the mid-columnar level, but the only principle is that it should be a staggered incision and not a straight line. So we always join the mid-columnar incision with the rim incision. And the rim incision is then connected with the infracartilaginous incision. These are my old surgical videos because right now I'm in Tinsukia, and all my other videos are in my laptop there in Guwahati. So nowadays I have started giving incisions from lateral. I first give an infracartilaginous incision, then do the rim incision, and then later on I give the mid-columellar incision. I've seen that this step has in a large way helped me in protecting the medial crust of the lower lateral cartilages while I give the mid-columellar incision. So this is lifting the skin soft tissue envelope over the nasal dorsum. While you're lifting the skin soft tissue envelope, you have to be in the lower part of the nose, the cartilaginous part of the nose. We have to be in the supraperichondrial plane. And once we reach the bony part of the nose, we then go subperiosteal. So the first thing that is done during rhinoplasty is hump reduction if the patient is having a hump. So humps can be bony, or it can be cartilaginous, or it can be composite, where the hump is both in the bone and the cartilage. So if you're taking off a bony hump, you either rasp it or drill it down. But cartilaginous humps, they always need to be incised. We have to be careful about lifting the periosteum out carefully out of the bone while we are doing any rasping work, because if the periosteum gets entrapped along with the bone, there will be significant pain during the postoperative period. So after the hump has been taken care of, all attention is paid to the septum, and we are all familiar with the dictum: as the nasal septum goes, so goes the nose. And so we have to do a really good septoplasty in these cases, especially when the noses are crooked in the mid part and the lower part. So the only thing about doing septoplasty with an open technique is that we approach the septum from the front, that is in between the ligaments of the medial crust, and then we identify the anterior nasal septal angle, and from the anterior nasal septal angle we identify the caudal border of the septum, and then we raise mucoperichondrial flaps on both sides, as we have been doing in septoplasty. So nothing more to say in this slide. We all know how to do a good septoplasty. So moving on to the next slide. So this is a caudal deviation, and this is the post-op picture. So a quick word about extracorporeal septoplasty. If the nasal septum is very crooked, as we have seen in my opening slide, then just doing a septoplasty won't suffice. So the whole of the septum is extracted out. Then it is reshaped on table like this, and then the septum is sutured back into the nose, and keeping in mind that it is fixed to the keystone area and the anterior nasal spine. These two fixation points are very essential when you have taken out the entire septum. So if there is any deviation in the upper bony vault, then a series of osteotomies are performed to take care of it. So we start off with the median or the paramedian osteotomies, which separates the nasal bone from each other and also from the septum below. This is done intranasally through the intraseptal approach. So this is the median osteotome. This jutting end at the top, this helps us in palpating the tip of the osteotome while you're doing the osteotomy. So the tip should never go beyond the medial canthus. Transverse osteotomies can be done, and this separates the bony pyramid from the frontal bone. Remember, transverse osteotomies are not done in all cases, and it will depend on your preoperative analysis whether you need a transverse osteotomy for your patient or not. And this is made at a level just below the nasion. Intermediate osteotomies are done if the nose is convex on one side and concave on the other side. And intermediate osteotomies are always done before lateral osteotomies. So lateral osteotomy, these are done along the allofacial groove, and we let me move on to the next slide. So this is the lateral osteotome, and it can be done both intranasally and percutaneously. This clip, you'll notice that the field looks quite bloody. Please excuse that. This is an older video. Nowadays, with the use of cold saline soak sponges during osteotomy, we rarely encounter this degree of bleeding. A simple refinement which helps the pill to stay clean. So after lateral osteotomies have been performed, we can infracture the bone to reduce a wide dorsum, or we can outfracture it to make it wider if the nose is narrow. Then a crooked nose can be tilted back. So a wide range of maneuvers can be performed after doing the lateral osteotomies. So this is a C-shaped deviation which has been corrected using osteotomies. This is another patient showing a S-shaped deviation, and this is her post-operative picture. So now about the middle cartilaginous vault. So the middle cartilaginous vault is made up of the upper lateral cartilages, the septum complex, and once we release the skin soft tissue envelope and lift up the mucoperitoneal flaps, then this part of the nose can be addressed. So if we need to recreate the nasal dorsum, like in this patient who had a severely depressed nasal dorsum, we can harvest cartilage from the auricle by a post-auricular approach, or rib cartilages can be harvested. Then these cartilages can be fashioned to recreate the nasal dorsum. So this is a patient. There is still significant edema in this patient because this photograph was taken just 3 weeks after the approach. So you can see that in the external approach, there is significant post-operative edema of the nose, and this edema, it lasts sometimes up to 6 months. So you have to counsel the patients accordingly. So this is another patient in whom the nasal dorsum was recreated. So now about the nasal tip. So the nasal tip is made up of the lower lateral cartilage, and the lower lateral cartilage has the medial crust, the intermediate crust, and the lateral crust. So we use quite a bit of sutures to reshape the nostrils. So I have this short clip here. This is not my own clip, but you can see that how sutures are being used to reshape and modify the nasal ala. So a bit about preservation rhinoplasty, which is being which is very how do I say that? Yeah, this is being done by most of the practicing rhinoplasty surgeons. So this is a clip. This is a pictorial representation about preservation versus structural rhinoplasty. So this Q-tip, suppose preservation rhinoplasty is basically done in cases where there are humps and we need to take them down. So earlier, what we used to do, we used to chop off the nasal hump at the top and leave a defect, like a open roof defect like this. Okay, and so we had to recreate this, we had to close this open roof defect. That means we had to recreate this Q-tip again with cotton. But in preservation rhinoplasty, what we now do is we chop off the bottom end of the Q-tip so that the Q-tip can be made brought down, the hump can be brought down, and preservation rhinoplasty is can be done by many methods, and this is beyond the scope of this lecture. So moving on to the next slide. So regarding complications of rhinoplasty, so intraoperatively there can be bleeding. You have already seen in the previous clip. There can be postoperative edema and ecchymosis. There can be infection. So this is a rhinoplasty patient who got post-op infection. And then there can be colomellar skin necrosis also. A disclaimer, I have not done a revision rhinoplasty case as yet, but here I want to just highlight this case here. This was a young boy who had an almost bifid nose, and when I did the case on table, the result looks somewhat like this. And the patient came back after 6 months, and the nose ended up looking somewhat like this. And I remember this story that Baser sir always tells us in all the workshop. He was going to his place of work, and then in the waiting room he saw a patient. He told his colleague, this is a very good patient for rhinoplasty. And then his colleague said, sir, this is the patient that you did rhinoplasty for 4 years back, and now he has come again. So there is this paper by Hassem Salah where he says that a bad looking nose can be made into an acceptable nose, or maybe a good nose. But a bad looking nose, if the patient expects that it will turn out to be a nose of a celebrity or something like that, then that is not so. And that lesson is for the surgeon as well, I feel. So always respect the support structures. Functional correction should be a priority. We must photograph everything. This is essential for planning as well as for medical legal purposes. And finally, we should avoid overcorrection. Less is often more. So ENT surgeons are best placed for holistic rhinoplasty. Preoperative counseling and assessment is as important as the operative procedure. We should always start with simple, straightforward cases before tackling complex ones. And remember, form and function are inseparable. Thank you.
Thank you, Anandita, for your wonderful presentation. And now I would like to request Professor Rakesh Kumar to give his opinion on this presentation and also input to the subject.
Ma'am, I must congratulate first the northeastern branch of AOI to taking this initiative for academic feast for we all to attend and learn. And also Dr. Anandita, I must compliment that the way you have covered the subject within a limited time span. This was excellent. You have covered from the cosmetic aspect, the structural aspect, how you work up the case, importance of photographs, and the basic technique, and then completed with complication and pulse and wisdom with your experience. So that was excellent. And for the beginner who want to start the journey of rhinoplasty, this should be more than enough. Regarding the few questions were coming up, as Dr. Anindita also said, each aspect like working up, how you counsel your patient, that is again in itself is a big subject, and it was not possible to cover everything within such a short span. So the purpose of these classes or the webinar is to create interest, go and read more and more, and also get the opportunity to observe or assist the cases so that you know exactly what has been taught and how it is being done. And then you again read. So this is way you have to learn and also attend courses, which may be hands-on courses and maybe someone live surgery is happening. So go there. Regarding Dr. Ananda, you say it is the surgery which bleeds significantly. I remember when I was PG, so I've gone to library and just as you know, the first thing you have to read the basics and it was boring. But just it happened that I went on to rhinoplasty chapter and it was so good, pre and post op. So that created interest. But when I was seeing first time Professor Deka doing it and start bleeding, I saw, oh, this is such a bad surgery. So for a beginner it may be, but for all rhinoplastic surgeon, we know when we do lateral osteotomy, it bleeds. So bleeding is not a problem. How you control that is a problem. Uh, uh, if you know that you can control it, it should be okay. Only one or two minor point. Uh, uh, I am sure that you know it, but the thing is, you can't fix everything. So one is that the where you are working, the ethnicity of the person. So it is northeast, the noses are different.
Yeah.
Same way, maybe Kashmir, it is different. The
Yeah.
South Indian, it is different. So you just keep in mind which area person belongs. So accordingly, you try to reconstruct. And also, you have rightly mentioned the face, the nose, overall build has to be seen. Someone who is 6 feet, you can't make a small nose, straight nose, male person. Better to leave little hump. So that gives little maleness and also the apparent appearance of a big nose for a big body. Someone who is small built, again, you have to make a small nose, you can't leave a hump. Regarding nasal bone, because we all read textbook which are from West. So West, it is always, you see that the nasal bone make always 1/3. But when we see our nose, sometimes it may be 1/4, 1/5. So smaller is the nasal bone, then osteotomy may not be that effective. So that should be kept in mind. Uh, Photograph rightly said. Only thing I usually tell my patient, either you take your photograph, so that is ideal, but most of the time it may not be possible. So you tell that get it from photographer. I usually click photograph with their phone and give it to them that frontal, side, basal, at least these 4 photograph I need. Tell your photographer, click the photograph, don't edit. No editing, whatever he is clicking, bring that to us. Because otherwise, sometimes you find that pre-op photographs are better than the post-op. Post-op, you don't edit, but the patient has pre-op edited photograph. So that confusion can be avoided. Regarding septal cartilage, try to preserve as much as possible. Don't try to sacrifice a cent. Because the previous concept, the dorsal stud, caudal stud, about a centimeter and a half, that is fraught with danger. Minor trauma, maybe little hematoma may lead to collapse. So try to preserve as much as possible. Take out whatever you can't keep it or what you require to make a spreader graft or reinforce the structural support or you want to do septal extension graft that you can do. Extracorporeal septoplasty, yes, some cases it is indicated, but for the student, it is very few indication for extracorporeal septoplasty. So that they should keep in mind. I think excellent talk, excellent lecture. I congratulate you, Dr. Anandita.
Thank you. Thank you so much.
Thank you.
Thank you.
Over to you, Professor Birajdas, sir.
Yeah.
Uh,
So, Anandita, congratulations.
Thank you, sir.
Yeah,
Thank you so
really,
much. Thank you
it
for
is
giving me
very,
this opportunity to
yeah,
present in front of all
the
of you.
very important thing is that your presentation, your description, everything is good. So far, the basic is concerned. But you studied rhinoplasty in Guwahati Medical College while I was there. So
Yes, sir.
we started in 1991 after coming back from AIMS. I saw only few cases of RC Deca where there is bleeding, bleeding, bleeding. So that time Rakesh was also there. So that is my experience. After that, slowly we joined FRCSI and we saw so many surgery and we are doing. But we have a limited cases there because of expectation of the patient. So always what I feel your explanation is really good, but so far the nasal angulation is concerned, it is not definite because it is there is ethnic variation. So
Yeah.
somebody needs 90
Yes.
degrees, somebody needs 110 degree degrees. So when you see the beauty of the face, the nasolabial fold should be good one, and columnar, there should be a prominent nasolabial angle also during smile, during flaring of the nasal alley like this. So these are the points of beautification. So expectation of the patient is very, very important to study. How much the patient expect? At
Right,
least
sir.
you'll have to never promise miraculous result, and be aware of psychiatric patient. That is very important. And your record keeping is really good so far as what you have shown about your photography rightly. But whenever you go for surgery, always you give more importance to bony wall first, because the narrowing of the bony wall is very, very important by proper osteotomy, what is required. And second is remodeling of the tip from the dorsum and increasing the tip projection and correcting the saddle when it's there, or what hump is there. But hump is also accepted in Kashmir. So pitfalls, so far there are so many pitfalls. Already revision surgery is always difficult, as you already mentioned, and he explained the likely outcome of the operation. It's very important. Otherwise, patient may have a more and more expectation. This is about
Right, sir.
very exposure of the dorsum is should be before backwards, so that you can see the tip, the dorsum from the dome up to the bony area. If you don't see properly, the dissection won't be proper. And be conservative. You'll have to keep maximum cartilages, as already Professor Rakesh has mentioned. So really good explanation. Anandita, again, I'd like to thank you. Thank you
Thank you
very much.
so much, sir. Thank you. It was a honor and a pleasure.
So there are some questions in the chat box. So Anita, would you like to take these questions? I'll read it out on behalf of you. So first is from Dr. S.B. Fukan. Which valve is more important in functional rhinoplasty, and how it is decided?
Uh, Both the valves are important because the external nasal valve collapse will also be problematic for the patient. The internal nasal valve collapse will also be problematic for the patient. The thing is that external nasal valve collapse is visible and internal nasal valve collapse is not visible. So assessment of the patient pre-operatively doing the Cottle's test, this will give us a good idea that whether we need to address the internal nasal valve during the surgery or not. And if that needs to be addressed, that can be done by using spreader grafts.
So one more question from him: how body dysmorphic disorder can be approached?
Body dysmorphic BDD. BDD is that's a chapter in itself. So I purposefully didn't go into that during this lecture. BDD is can be evaluated while you are doing a counseling session with the patient. So there are some acronyms like Simon, Sylvia. So Simon is a male patient who is very immature and he is very aggressive. So those kind of patients.
You can stop your video and use your audio because your
Okay, yeah.
network is very poor at
Yeah,
this
yeah.
moment.
So yeah, so a good counseling session, if you are not sure whether the patient uh, is having BDD, you can always refer the patient to the psychiatrist or the psychologist for their opinion as well.
Okay. Dr. Sagata ma'am mentioned that it's an excellent presentation. Who is the best candidate for rhinoplasty? She wanted to know from you, who is the best candidate for rhinoplasty?
A person who has grossly deviated nose, a crooked nose, because correcting, if you can correct even a small degree of their airway function, they are very grateful to you. And what I mean to say is that if the nose is grossly deformed, if you can correct it to a certain degree, the patient appreciates it. But those kind of patients who they want to go for rhinoplasty just for cosmetic purpose, satisfying them is quite a task.
Yeah. Actually,
Okay.
I feel that the patient should be physically healthy, mentally stable. I think
Right.
they have the realistic expectation, and they to be satisfied with the improvement of functional and aesthetic improvement, but not the perfection. I believe so. So this type of candidates are the best candidate for your rhinoplasty.
Correct, ma'am.
What is your opinion, Dr. Rakesh? Is this the patient is the right patient for rhinoplasty?
Sir, please unmute yourself.
Ma'am, excellently explained in a one or two sentences. But one more thing I will add in the beginning, it is better not to take patient who have gross deformity or who has minor deformity. Take the patient with moderate deformity
Yeah.
and with functional issues, because as an ENT surgeon will be always advantageous position to improve the function. So function will improve. Whatever you improve above that, that is a bonus. So, but
Right.
your thing is first thing that is taken.
Thank you.
So I'll read out the compliments as well. SB Fukan sir has mentioned informative presentation of most sensitive surgery.
Thank
Um,
you.
um, um, SN Mukherjee sir probably he was asking importance of spreader graft from aesthetic and functional point of view. Yes. Hello.
Hello. Yeah, am I audible?
Yeah, audible.
Yeah.
SN
So,
Mukherjee sir was asking. You got the question?
yeah, I got the question. From the functional point of view, I've already mentioned that it is very important while addressing any internal nasal valve collapse. And as far as aesthetic aspect goes, yeah, recreation of the mid cartilaginous vault, the spreader graft has a very important role in that. It is on top of the it is on top of the spreader graft that if we need to recreate the dorsum, any settling of the nose, we place all the other grafts on top of the reconstructed cartilage, the spreader grafts, and then on top of that we place the all the other grafts. So yes, spreader grafts are very important both in the aesthetic and the functional correction of the nose.
Okay.
Can I add one point here? Is
Yes.
that spreader cup, whenever we are removing the hump, be it cartilaginous or bony hump, especially cartilaginous, where the possibility of saddle deformity can come. So we can at least avoid that, putting the saddle. It only adds to the support of the mid third of the nose, because that cartilaginous what is important. So that
Yes.
can be avoided by putting in the spreader cup. Moreover, it increases the inner, angle also inside.
Pragata ma'am was asking what is reconstructive rhinoplasty, corrective and post-traumatic rhinoplasty. Ma'am, can you clear it up?
What is reconstructive rhinoplasty? And what is corrective rhinoplasty? And what is post-traumatic rhinoplasty? These are all synonyms or different. These are the corrective rhinoplasty. Usually we are doing for crooked nose. Then post-traumatic rhinoplasty following trauma. This is, I think, this is post-traumatic. And reconstructive for soft tissue, I think, soft tissue correction. Dr. Anandit,
Hello.
yeah?
Yeah.
They
Yes, ma'am.
recognize,
You're
yeah.
very correct. Yeah. Reconstructive rhinoplasty is, yeah, when there is loss of any skin soft tissue envelope, then reconstructive rhinoplasty using a forehead flap, a
Yeah.
paramedian flap,
Mm.
and yes, post-traumatic rhinoplasty and corrective rhinoplasty, you have already said, ma'am. Right.
So, Arpita Mahanti She has mentioned, ma'am, it's a beautiful presentation. SB Fukan sir again asked one question: how much insurance professional indemnity you have? As
Me,
Fukan sir.
I don't have anything
Won't get, you won't get any insurance
because I work in a
Then
medical college. That is insurance for me.
for company purpose. No, not this.
No, in government college also you will not be spared legally.
Yes,
If
I
some
understand, sir. Yes,
Yeah.
you therefore be careful with the good
yes,
insurance.
sir.
Dr.
So
Rubia,
doing the cases correctly is important.
so it's a compliment from Dr. Rubia Nilakshi Chaudhary. And SB Fukan sir again asked, Michael Jackson has how many rhinoplasties?
6 maybe, sir. Am I right? No, more than that?
Fukan sir.
I think it is more than that. I have heard 9.
Oh,
Huh?
9. Okay.
I don't know.
Is there any structure left?
No, he had
Nothing
no
left.
nose left. Yeah, he had no nose
Yes,
left. He
nothing.
had a
Nose is not.
prosthetic nose
Yeah,
at
correct.
the end of his life. Yeah.
Only a
There-
jacket, I think. Only
I
jacket
don't
of
know exactly, but the newspaper, the thing, it was mentioning more than 42 or 45.
Yeah.
My God.
No,
So there was hardly any news left when this last picture came. There was already the tip was ulcerated out, and he used to wear the this thing prosthesis
Oh,
for his public appearances.
yeah.
It
But
was
okay.
hats
almost
off to
40 plus.
those surgeons who attempted to do the rhinoplasty.
They must have been sued.
Money is there. There is a demand. There is a supply.
Demand and supply.
There is a compliment from Kalpana Sharma ma'am also. Dr. Biswajit Gogoi was asking when you choose rib cartilage for augmentation.
Rib cartilage, yeah. When there is a
Augmentation.
major loss of the mid cartilaginous vault and the lower cartilage, then we need rib cartilage harvesting because of if there is a lot of settling, then we'll need a lot of cartilage to reconstruct the nose. Then the auricular cartilage might not be enough. So then, yes, we have to go for rib cartilage harvesting. But now, during my last visit to Basir sir, I have seen him recreate a nose, a saddle nose, just using the both the auricular cartilages, and
Yeah.
this technique that he showed. It was really marvelous. The results, the post-op result was also marvelous. So, yeah, maybe if we can refine our techniques, we might not need to go for rib cartilage harvesting.
I
But
think in
depending
some
on
cases of revision rhinoplasty, you may need sometimes
right.
cartilage.
There was a question from Anisha Ganguly. For the nasal tip correction, would you prefer a septal extension graft or a columellar strut or both, ma'am? She was asking.
Uh, for the nasal tip correction, we use a septal extension graft when we want to lengthen the nose.
Lumila.
But it is not for tip.
Yeah, it is not for tip correction as such.
Correct.
For tip correction, we use the sutures, different types of sutures to
Yeah.
remodel and reshape the nose. And septal extension graft is for lengthening the nose. And columellar strut, I put in all my cases because I always do open rhinoplasty. I've been doing open rhinoplasty only. So when the ligaments between the middle crus are cut, you need to strengthen them using the columellar strut.
Okay, final question from Dr. Anjan Jyoti Bhuya. Minimum and maximum age for rhinoplasty.
Maximum age, I don't think there's any limit.
Anything.
I don't know. Yeah. If the patient desires, and as Rakesh sir has said, if there is a demand, then we need to supply. And minimum age, I have seen a lot of pediatric rhinoplasty cases being done. The minimum age that I have myself done for a patient is 15 years. So this patient that I'm talking about, he had grossly deformed, no, not grossly deformed, please excuse me. He had a severely deformed septum, S-shaped deviation, And this S-shaped deviation was giving a crooked appearance, external appearance to the nose as well. So I have done septorhinoplasty for this patient, but I have gone for the minimalistic approach. I have not done any osteotomies for this patient. I have not harvested any cartilages for this patient. The severely deformed cartilage, whatever I could take out, I have reshaped it and done it for him. Yes.
Age
Anjan also.
before, excuse me.
Yes.
Hello. Age before 16 years, septal cartilage still grows. And that's why you should confirm that age is a very important below 16 years. That is my experience. And age after 45 years, skin may not settle properly. That is also one important point. These are pitfalls, what I say. Okay.
Anjan also wanted to know what type of sutures you use.
Yeah.
We use PDS sutures because PDS sutures they
Stays for
last
longer,
for a very long time.
longer time.
The
Yeah.
absorption is around 9 months, I guess. So till that time that the fibrosis and everything takes place. So we use PDS sutures.
Okay, if there is no questions in the chat box, can we wind up at this time? Shagita ma'am?
Yeah. Is there
Yeah,
any questions? Is there any no questions?
there is no questions.
What is the advantage of PDS over other sutures?
Longer duration
Yes,
stays.
yes, I think yes.
Wait.
Longer
Anand-
duration for absorption.
Yeah.
Unobservable.
I think Anandita, your presentation was really good.
Thank you
cell phone.
so much, sir. Thank you.
Very nice presentation.
Very nice presentation.
Very
Okay.
In
Very
Ritipik
So,
also, the name of the Michael Jackson comes after you have mentioned Jubin Garg, because he took the fourth position after with the
Yeah, of course.
greater crowd gathering is the Michael Jackson, then Pope, then Queen Elizabeth, then Jubin.
Yeah. It is
okay.
in Limca.
Thank you.
Yeah.
Okay, then we are winding up. First of all, I would like to thank Professor Rakesh Kumar for joining our Nevoy classroom.
Thank you.
Thank you, sir, and thank you for your inputs into the
Thank you so much,
subject.
sir.
Yes. I would like to thank Dr. Anandita for your wonderful presentation, and it is very informative. I'm sure that everyone will be benefited from this who have joined this classroom, as well as from our YouTube channel, which is linked to our Neboy website. I'd like to thank Professor Biraj Das sir for your valuable inputs, and you are present in our classroom, but this time as a moderator. Thank you, sir, for joining as a moderator, and I thank all the participants here for your interaction and also presence. Thank you, everyone, and thank you, everyone. I conclude. I